So hello everyone, I hope I'm audible and visible. Just give me a quick thumbs up if you can hear me. If I'm coming online, just give me a quick thumbs up, all my dear students. Let me also check. Oh yes, great. Yes, great. Okay. So I hope everybody of you or every one of you have done the paper well, and I'm sure that your paper was. Can you tell me how was your INICET overall? Because I'm getting a mixed reviews from all my students. Few says, ma'am, that it was very tough. Few says that, ma'am, a lot of repeats were asked. So with respect to dermatology, almost all the questions, although we got a lot of repeats this year, but almost all the questions were from the T&D which we have discussed in DAMS. So I think those who were there in that T&D session, they all were very happy after this. How many of you agree with me? Can you give me a quick thumbs up? Okay, chalo, great. So let us discuss the INICET Dermatology Recall. I would request my students to kindly correct me wherever you feel that the language of the question is not correct or the options given were not correct. This session is a pure recall based session, so it may not have any exact image which you got in the exam. So I need your support. I want you to correct me wherever possible. Okay, so let us start with the session first, and this is the first question. I request my students to kindly answer this question. There was a match the following type of question. On column A, they have given the name of the infections, and in the column B, or the diseases, and in column B, they have given the color which you see on the fluorescence for all these conditions. So I request my students to please try answering this question. It's a very easy. This we have already done in the T&D session, the live T&D which was there on eMedicoz app. So I'm sure that those who have attended that INICET T&D, they were very happy when they saw this question, right? Yes, very nice. So in this question, you can see that the infectious diseases, erythrasma, which is a Corynebacteria minutissimum infection, it classically presents with a coral red appearance when you see it under the wood lamp examination. And if you remember, the same question or a very similar question on erythrasma was asked in the last INICET also. So this is sort of a repeat question. Then we have pityriasis versicolor, which is a Malassezia furfur or a fungal infection, yeast infection. When you see it under the Woods lamp, you will get a yellow color fluorescence. Tinea capitis, the most common species causing tinea capitis is Microsporum, and when you see it under the Woods lamp, you will see a bluish green sort of fluorescence. In vitiligo, when you see it under the Woods lamp, the white color becomes more prominent. It becomes ivory white or milky white. While the pink color fluorescence is mainly for the porphyrias, the blood and the urine shows a very classical pinkish red hue. So for this question, the correct answer should be 1B, 2A, 3D and 4E. I'm not sure whether these were the options given, but I'm sure that the column A and B includes all these examples. So this was the same question, and I'm very happy that the students, they were aware of this. This was not a bouncer for any one of you. Coming to the next question, again, non-scarring alopecia. How many of you agree with me that this is again a repeat of INICET last December or the last 2022 INICET? Direct repeats we are getting. The question is, non-scarring alopecia is a feature of androgenic alopecia, tinea capitis, frontal fibrosing alopecia or alopecia areata. Now, I'm not very sure that whether they have asked that all of the following, I think there was a except which was given here. Non-scarring alopecia is a feature of all except. I think that was the question, right? So can you tell me what will be the correct answer? Androgenic alopecia, tinea capitis, frontal fibrosing alopecia and alopecia areata. This is a direct PYQ, and anybody who has attended my INICET T&D, this question was again present there. So second question, which was a direct repeat. Please remember, we have divided alopecias into two groups. One is scarring and another is non-scarring alopecias. We have divided non-scarring into 3 A's and 3 T's: alopecia areata, androgenic alopecia and anagen effluvium. And 3 T's: trichotillomania, telogen effluvium and non-inflammatory tinea capitis. While scarring alopecias are lichen planus associated alopecias, DLE related alopecias, frontal fibrosing alopecias, and there were many more. So here in this question, if they are asking you except, then the answer becomes option number 3, because frontal fibrosing alopecia is a scarring or a cicatricial alopecia. So can I get a quick thumbs up from all of you? This was a repeat question in dermatology. Again, I always tell my students that there is very minimal experiment which we see in dermatology questions, and this is the example. So second question, which is a repeat. I just need a quick thumbs up from all of you if this is clear to everyone. Yes, can I get a thumbs up? Great. Now another question. Now this was a question, students told me that there was an image of DIF given, and they have mentioned in the question that there were linear deposits of IgG or C3. Now why I have put a question mark, because few students say that there was a drug, a biological drug given here. So I need to ask it from all my students, was there any drug given here? And like the question was that a patient on this drug presented with blisters, and on doing the DIF we could see a linear deposits of IgG and C3. So please, I request my students to help me with this question, whether we had any drug, because there was a drug novilumab. I don't know whether this was the drug which was given here or not. I'm not very much sure whether this was given or not. Okay, so even if they have given a drug, and even if you do not know that drug, the question and the options which were given, it was directly pointing towards bullous pemphigoid. I hope I told you, or I hope you remember, that bullous pemphigoid, you see IgG against BP antigen 1 and BP antigen 2. BP antigen 1 was a component of hemidesmosome, while BP antigen 2 was a component of lamina lucida of basement membrane. I told you that amount of BP antigen 2 were very high. The amount of antibodies against BP antigen 2 was very high, and that is why in the patients of bullous pemphigoid we see a split at the level of basement membrane, and that is always linear. So students say that the question says patient presented to us with pruritic urticarial lesions. Very nice. So that is one more addition. Pruritic urticarial lesions associated with following DIF finding. What is the answer? The answer is bullous pemphigoid, because you see a very classical linear deposits. In pemphigus foliaceus, in bullous pemphigoid, what is the DIF appearance? You see what is called as a fish net appearance. And the reason is because the antibodies are against the intercellular component. And what is the intercellular component? It is the desmoglein. In dermatitis herpetiformis, you see the deposits along the basement membrane, but they were not linear, they were granular. So this cannot be a granular appearance, it is linear, so this cannot be the answer. So the correct answer was bullous pemphigoid. Again, a same question which we did in eMedicoz, INICET, T&D. So those who are attending these sessions, I'm very happy for them, because all these questions were directly from that sessions. The next one. Now again, in this particular question, I'm not very sure whether they have given you two images or not. So Kshitij and Tasleem, I just want you to tell me whether these images which I have attached here, whether they are correct or not. The question says that a patient with following itchy scaly lesions, which of the following is diagnosis? Now some students say that they have characteristically mentioned the Christmas tree appearance. In the question, somebody says that they have mentioned this word, and few students says that they have written that the scales are present on the periphery. So I want my students to let me know whether these two appearances or whether these two classical pictures were given or not. The first image shows the Christmas tree appearance, and another is a peripheral scale, which is a very classical the classical appearance which you see in the patients of pityriasis rosea. So the answer is option number 1. Pranav says that, ma'am, on the option it was written that it is the Christmas tree appearance. So if that is the case, we can write it here that the appearance is very, very classical. What is pityriasis rosea? It's a viral infection secondary to HHV 6 and 7. After a prodromal stage, patient develop a single large patch which is known as Herald patch. It has a very, very characteristic peripheral scale. The scales are attached to the plaque with only one margin, and that is why we call it as a collar-like scale. Second thing is, after a gap of 1 to 2 weeks, we will observe that there is distribution or there is development of multiple daughter patches which are distributed throughout the body in a very classical Christmas tree appearance. Ma'am, two options with Christmas tree appearance. So Samruti, can you just try to recall and tell me what were the difference? Because see, Christmas tree appearance, if two options are given, then they must have given something else so that you can mark one answer from them. So can you just help me whether they have written collarate scale along with Christmas tree appearance or something else was given? Because if there are two options, obviously you need to rule out one of them, right? So anything which you can recall, just let me know. Okay, great. So I want others also, so please give the input so that we can make a correct recall. And also with respect to the image, was the image only showing a Christmas tree appearance, or we had an image which which has both collarate scale and Christmas tree appearance? So these are the two things I want my students to please help me with. Great. Okay, meanwhile, the next question was somewhat like this. A patient with flaccid bulla and suprabasal acantholysis. Now students say few of them have remembered that there was an age given here, that it was a 60-year-old female. I'm not very sure whether the age was given or not. So Vignesh, was there any age given in this question? A patient with flaccid bulla, suprabasal acantholysis, this is the assertion, and the reason is row of tombstone appearance is seen in the patients of pemphigus vulgaris. Now first of all, what is pemphigus vulgaris? It is an autoimmune vesiculobullous disorder. So it is an immunobullous disorder where you develop IgG against desmoglein. We have two types of desmoglein. In the patients of pemphigus, antibodies are more common against desmoglein 3 compared to desmoglein 1. Okay, so that was the question. So pemphigus vulgaris patients, because of antibodies against desmoglein, you see a very classical suprabasal split, because the amount of desmoglein 3 is more common at the lower levels of the epidermis. So option number 1 is correct, because it is an intraepidermal split, it becomes flaccid, and it is a suprabasal acantholysis. So this is a correct statement, true. Row of tombstone appearance is also seen. This is also a correct statement. But what is the reason? The reason of row of tombstone is that in the patients of pemphigus, you have intact hemidesmosomes. Hemidesmosome is also a glue like desmosome, but they are only present at the lower layer of the epidermis, connecting the stratum basale with that of the basement membrane. Why you develop suprabasal split or flaccid bulla? It is not due to the presence of hemidesmosome, it is due to antibody against desmoglein. So please remember, both these statements they are correct, but they are not explanations of each other. So for this question, the answer should be both assertion and reason are true, but the reason is not the correct explanation of the assertion. So because both are true, the reason for flaccid bulla and suprabasal split is because you have IgG against desmoglein 3. And the reason for row of tombstone appearance is intact hemidesmosome. So the answer here becomes option number 2. Now few students said that there was a question, what are the clue cell? Now here I have some doubt whether the image of clue cell was given or not, and what are the other options. So I want my students to help me with this. Inflammation was also given in assertion. Does that not cause row of tombstone? See, the reason for row of tombstone is why you see, first of all, understand, Vignesh, what is row of tombstone. In pemphigus vulgaris patient, you see intact stratum basale. The reason why stratum basale cell remain intact is because they have a glue which is present on the undersurface. So it is the hemidesmosome, the intact hemidesmosome, which is responsible for the row of tombstone appearance. Nothing related to inflammation as such. See, if there is inflammation, you will see cell separation, right? So you can prove acantholysis with inflammation. But row of tombstone just give you an idea that you have an intact stratum basale. Okay, so I hope this is clear. Okay, so Ashran says that they have added one more word, that row of tombstone is diagnostic. Diagnostic, was it given like that? Diagnostic. Still, if they write it is diagnostic, then also it is correct. Okay. So what are the clue cells? Please remember, clue cells, they are features of bacterial vaginosis. Bacterial vaginosis, what is this? It is a condition in which the vaginal pH changes. I hope you all know that the pH of vagina is usually acidic, and the reason for this is we don't want unnecessary bacteria to colonize our vagina. So we have acidity or acidic environment due to lactic acid released by lactobacillus. But in few females, the high risk females, the amount of lactic acid or lactobacillus goes down, and when the amount of lactobacillus goes down, there is a large number of colonization of bacteria. A large number of bacteria colonizes the vagina. Now you can see, I want everyone to look at this image. If you take a swab in a normal female, you see vaginal cells with few bacteria on its surface. But in a patient of bacterial vaginosis, when you take a smear, you will see a large number of bacteria which are present on the surface. There are a large number of bacteria which are present on the surface. They are not inside the cells. So normal vaginal epithelial cells with large number of organisms on its surface, this is known as a clue cell. So according to the, I don't know what are the other options. Can you all help me with the other options? The answer of this question is epithelial cell with bacteria on the surface or at the borders. It is not macrophages with brodeline bacillus. No, it is not correct. The correct answer is option number 1. Clear? So that is about the clue cell. Now, I am not very much sure whether this was the image given or not. Now, students say that there was an image given. Somebody says that the image was like this, where you see S-shaped pattern on the back and on the front. If you have S-shaped pattern, it is a Blaschko's line. These are the embryonic lines through which the embryonic cell travels. While Langer lines, these are straight lines. They are not S-shaped lines. And these lines are important for the surgeons because they are minimal tension lines. Whenever they need to give an incision, they give along with these lines so that the healing occurs better. Okay, so I am not very sure whether this question was given or not, but students say that there was one of the image and this was the options which were asked. So Vignesh, relaxed skin tension lines were there. So you think that these were the lines which were given? I'm not very much sure what was given in the question. So Langerhans lines are the minimal tension lines. Okay. So Langer line image was given. Yes. So if this, because Blaschko's line has a very characteristic S-shaped pattern. So please do not get confused. S-shaped pattern is Blaschko's. While here, if you see, there was straight lines. They are the relaxation line or minimal tension lines. So the answer should be the minimal tension line or the relaxation line. What about scalp? Yes. So Rajesh, obviously it is very difficult for us to differentiate a Blaschko line from the scalp lines, especially on scalp. Both of them are straight. But if you compare it on the other part of the body, that is why some students have told me that they have given or they have attached the image of trunk as well as the face. If you have images of trunk and face together, it becomes easy for us to differentiate both of them. Right? Clear? Okay. So these were the questions. If you feel that I've missed any question, I want my students to please, try answering it on the chat section so that I can add them and I can make a perfect PDF for everyone to, refer it. Now I have few questions. Let me see the questions. Isn't row of tombstone appearance also seen in pemphigus foliaceus? Ashrant, no, you never see row of tombstone appearance in patient of pemphigus foliaceus. And why? Because pemphigus foliaceus, the level of split is superficial, subcorneal. You are not able to appreciate that, a stratum basale cell standing alone. You cannot appreciate that because the split is so superficial. You only see row of tombstone appearance in pemphigus vulgaris patient because the split is at the level of stratum basale or above. The cells of stratum basale, they are separated from each other, but they are connected to the basement membrane, giving it a classical row of tombstone appearance. Okay. Purvi, no scarring alopecia question I've already mentioned. Anything else was there? I'm not sure. Purvi, there was one more question, or only this question you're talking about, non-scarring alopecia? Face image was helpful. It was horizontal lines on the face. So Vignesh, yes, I told you, right? If they have to give some images, either they will give or they will add face plus trunk, because it is very difficult. Few spaces or few places, they all are straight. So I think your dermatology was easy, and I'm very happy that like we have already discussed these questions. Not much difficult questions. I think there was one more question on slap cheek appearance. There was a question they have asked about the organism causing the slap cheek appearance. I'm not very sure, but there was one question on that as well. Telogen effluvium option was there. Is there any question on telogen effluvium, or you are telling me that one of the option here was telogen effluvium? So we had 5 options. Okay, so one more option we had, and that is telogen effluvium. Please remember, telogen effluvium is also non-scarring. This is also non-scarring type. Great. So telogen effluvium was also one of the options. Please remember, still the answer remains same. In telogen effluvium, in alopecia areata, tinea capitis, especially the non-inflammatory type, that is black dot and favus, will present with a very classical non-scarring type of alopecia. Okay, so I think we are done with all the questions. Thank you all of you, and all the best for your results. Hope to see you soon. If you have any doubt, just connect with me on the Telegram group and we'll have the questions.